So the next talk is from Dr. Mukherjee. He will speak about hernia repair with a robotic. We're very interested in your video. Thank you very much.
Everybody, before I start, I have to make an apology. So Sanjay Mandal, who's the organizer of this event, asked me to show a robotic giant hiatal hernia, which I did exactly 2 weeks ago, and the patient was discharged. I found that only the stills have been saved and not the video. So I went back to him and I said, look, what I'm going to do is it's not this one actually. Can I go to the first one? Second one, yeah. This is the PowerPoint. Shall I control it? No, this is not the one. So if you go back to the folder. So in this situation, all you do, can I just go back to the folder, please? Yeah. This is not the video. This is a talk from tomorrow. Go back to the folder. Yeah, that one. Yeah. That one. No, here. So what I did is to actually phone a friend. There are not many people who are using robotics, and I'm doing it only for 1.5 years. I'm a very high volume giant hiatal hernia surgeon, so I do possibly something like 2 or 3 a month. Now, the technique that you see is from my young friend, Mr. Van Boxel, whose technique is quite different from mine, so I'll just talk you through. And I'll stop it at 6 minutes, and then I'll show you another video. These are technical videos. This patient essentially had a lot of pain, and I'm going to talk more about robotics rather than this video itself. The difference is setting up. I don't know how many of you do robotic surgery, but one advice that I will give, being a new learner, only 1.5 years, I've been competent, that you have to respect the robot. It's a very strong beast, and you can have problems. And it is very, very important, the setup, the targeting, the docking, all those things are very important. We upper GI surgeons are late entrant in this field. In Holland, they're doing a lot. I have probably done no more than 10 of these in robotically, so I feel like a fraud as an expert, but I do a lot of giant hiatal and have done for about 20 years now. So the difference that you see is that, first of all, I don't do it like that. I will actually reduce the hernia. The fixed part of the hiatus hernia is going to remain in the chest, and after that, we'll start dissecting. The advantage of robo is that you are completely autonomous. It's quite a nice thing once you start doing it, and when I was told by some of my colleagues that once you use robo, you'll not go back to laparoscopy, I can see why they said that. I don't think I'll be a total convert for every patient. You have to select them carefully. So this is where you can have the fourth arm of the robot, which actually retracts everything, and your assistant is fixed. The problem with that is that if you pull, then you're pulling between 2 fixed points, and you can have a rupture and you can have an injury. So if you look what he's doing is actually not reducing and getting very close. And this is something that is a very new thing in robo. You are basically working right in front of your eyes, yeah? And you're not used to that. So you become sort of, you cannot be presbyopic. You have to look very closely. The advantage, obviously, which you'll see in a minute, is extreme degree of freedom. So when I got one of my trainees to start suturing robotically, they just took, in the simulator, they took it on very easily and they learned it very quickly. I think there is some evidence to say that if you're an open surgeon, you're probably better off going straight to robotics than if you're a laparoscopic surgeon like me, because we work from our shoulder, yeah? Whereas in robots, you're actually working from your fingers. And it's a really big shift, actually, and it takes time to get used to it. As you can see, he's just doing a standard crural repair, but if you look, the field is actually much closer than most of the laparoscopist is going to use. The advantage of these articulated instruments are huge because they can do things that your laparoscopic instruments cannot do. They're articulated. And I know there are laparoscopic instruments also available which are articulated. But this gives you an immense freedom of movement. But make no mistake, and this is a word of caution, that although these instruments look very delicate, yeah, and somebody was telling me earlier on about a pretty lady, yeah, how they lose their charm. I think the person in the audience will remember this. Remember that although these are very pretty instruments, they are incredibly strong. And this is something that you have to remember, that when you do this in the hiatal area, you have to be very careful, because unlike colon, I would say, you have got heart on the top, you have got IVC on the corner, you have got esophagus. Actually, portal vein is not that far away in this field. So you're essentially working in about 5 centimeter square area, and everything is exaggerated. What he's doing now is a Watson's wrap, which is something that I don't do. I don't think it's a bad thing to do. There's a lot of randomized control trial to say that, The results are same. I do a Nissen, but that's that. So he's doing an angle of his repair, and then he's going to do a Watson's. So this is the difference between Dorr and Watson. So you fix the stomach to the esophagus, and then you do a anterior wrap. So that's what he's doing. I'll stop that video, and can I go to the next one, please? Actually, just leave it for one minute. Yeah. So let's see the stitching bit, because actually these instruments are very, very versatile, and you can do things. So when you start doing it in the simulator, everything moves, and you think it's a very strange thing to do, but you get used to it much quicker. I certainly remember when my life has been as a laparoscopic surgeon for the last 21 years as a consultant. But actually, I must admit that learning this is quite easy. However, it has to be structured. Do not just take it on. Robot is a very strong horse who's going to get you off his back if you don't learn how to ride that beast properly. And that involves essentially dry lab, wet lab, observation, and then proctoring, and then being declared as a competent. So although I'm a very senior surgeon, I had to go through the whole lot as a trainee does, and that is something that I would say that you have to invest that time and energy. It's not that long, actually. Can go to the next one, please? Parahiatal hernia. Yeah. So this is a case which I did about, I don't know, next one, no, not that one. Yeah. Yeah, that's the one. Do you want me to run it? Yeah. So this is a patient who came with a standard giant hiatal hernia. So a lot of pain, difficulty in eating, extreme degree of chest pain, and often they get a left shoulder pain, as you know. And what you do is that he's just dissecting the hiatus. See the difference? I have not seen any stomach yet. Yeah. So I'm going to the anterior mediastinum, and then suddenly I see something that I think is riding from the left side of the esophagus. Yeah. So at this point, I'm still thinking that this is a hiatus hernia, but as I try, I cannot reduce it. I have already seen some adhesions on the left-hand side, and I'm slinging the esophagus, thinking that now on the left side of the esophagus there is a parahiatal hernia, esophageal hernia, which I can easily dissect. Except that it's not happening. And then I see, I can see a bit of stomach in the mediastinum. And then I see actually what is happening here is not the herniation through the hiatus, but through the left crus. It is a rare occasion where you get a parahiatal hernia. The reason I'm saying this is because you have to identify everything. Spend time in dissection. If you don't spend time in the dissection, you can be surprised as to, you may not be dealing with a standard giant hiatal hernia. The majority of the giant hiatal hernia has a wide hiatal defect, and you can see that the swab that I have left in the mediastinum from the hiatus, I can see through this defect. And essentially what has happened is that there is a defect in the left crus, and these parahiatal hernias are rare. They cause immense amount of pain and problem, and you have to identify this by dissecting. And you will always get these oddities at operation. None of the investigation is going to tell you this. I thought, looking at the report, and my interpretation was that this patient has a mesenteric coaxial volvulus in a hiatus hernia which has got about 2/3 of the stomach in the chest. I was wrong. And that is why these things are actually about sort of sharing our mistakes and follies. The insurance that you have got is that you have to really identify the defect. Now the mediastinum is empty. The stomach has been taken back into the abdomen, and I'm repairing the left crus. And these are small defects, and usually suture is enough. As Inian said, I use dual mesh when there is a wide hiatus. Here there is no wide hiatus. That's what I wanted to say. The wide hiatus is like a big cave, and they have got different shapes, as you know. This has been described by Demister, the U-shaped, the teardrop-shaped, the D-shaped hiatal defects. This is actually not a hiatal defect at all, except that I created one by dissecting the hiatus. So once you repair the parahiatal hernia, you still have to repair the hiatus itself, and because you have taken down the anti-reflux anatomical mechanisms, you have to still do a wrap, which is what I'm doing now, in a minute. So the standard steps of giant hiatal hernia, which is different from robotic, is that you put your retraction, go to the right crust, identify the left crust, to the white line, exactly like the fundoplication. The difference comes when you go anteriorly and you see the wrap. Okay, so this is now the sort of crural repair being done. And in this bit is actually quite easy because simply because this size is normal. Yeah, the herniation was entirely through the left side. And I know this is the jury is out. What you do, what you don't do. I'm very, I would say, old-fashioned perhaps that I do for most of the patients I'll do a Nissen wrap. My preference for Watsons or I don't do a toupee, but probably have done a couple in my life and I don't want to do them again. Not that it's a bad operation, but if I don't do a Nissen, because I think what happens is that if you work in one place, in the NHS, the patients will come back to you. So you are better off doing things that is going to last, and you have to really counsel these patients like everybody else. So this is a standard Nissen wrap and 360-degree wrap, and like most people, I'll do a short, floppy wrap. I don't use a bougie, but I think when you start doing these things, you have to use a bougie. Like what was shown earlier, I also fix it to the esophagus. I do not always fix it to the crura, except in giant hiatal hernias, which it wasn't. It was a parahiatal hernia. And that's the Nissen wrap being completed. What was really remarkable is the relief of symptom. This patient had no life at all. And she came back after a week. She went home the next day. She came back after a week. And the first thing she said, can I go for a holiday? Because apparently she was going to America to see her daughter. And that's what she went. And with these patients, when you have got a clear pathology like that, then, and you know exactly what the patient's symptoms are and what you're trying to do, then usually the results are very, very good. I think I'll stop the video there. Thank you. And there's not, okay, just let's let it run for another minute. What I want you to show you this, look at the quality of the first video and this. Yeah, this is HD. I can't remember whether it was 4K or not. But there is no question in robot you will fall in love with it, provided you go through the initial pain of learning it. And the reason is, as I was talking to Mr. Chakravarti in the audience here, is that it is just incredibly autonomous. You are the camera holder, you know exactly where you're going, you are the assistant, and everything is in your hand. Downside, obviously, you do have an assistant sitting with the patient when you're in the console. But the downside, obviously, is that you have to be your own assistant. You have to be very careful, because when you put the fourth arm on retraction, and it'll swap. Between what will happen is that your first arm of the robot is your left hand, then you have got the camera port, and it's true about all upper GI robotic surgery. And your third and fourth arm, you're going to swap. And when you first learn, it's exactly like driving that you may actually forget. So what you have is somebody watching over you. And you need to do that for a few cases when you become systematized. The other thing I would say is that there's a lot of evidence that you have to keep on doing it. So if you will forget very quickly if you won't pick it up like open surgery. It's not that intuitive. Thank you, I'm finished.
Thank you very much for these wonderful videos. So I have a question. What are the indications to use a robot in your hospital? So when do you decide to make it conventional laparoscopic, or when do you use the robot?
If I'm honest, I started doing normal fundoplications with robotic. And actually, I don't make any distinction at all. You can say that if you got fixed hiatus hernias, then you probably should not start with those. No, actually, it is easier. Once you've got the knack of handling the robot, it is actually easier for those reasons that I have said. The problem you do have is that when you've got a very close view, and that happened in initial bits of laparoscopy as well, you have to be very careful about remote injuries and stuff like that. But actually, you do not have to worry about a lot of other things. Whatever constraints that you have is actually far more outweighed by the flexibility of movement that you have got. Stitching is just incredibly easy. In fact, once you learn, and this is something that I'm not a new learner, so I'm no expert, so I'll share my journey with you, that I think I found it more difficult when I first learned stitching in the fourth year or fifth year of my medical school than when I started stitching laparoscopically. You have to do a lot of simulation. So you have to work on the bench, and the simulators are very good. I use a Da Vinci Xi, so I started with the best. So in some ways, my life was easier. People who started with the previous generation, they probably found it more difficult. But I think the upper GI robotic surgery has arrived. I think it's going to stay. And I'm going to make a comment here, which actually you may find very tall talk. Going through this journey, one thing I have realized that for the residents in the audience, if there is any, you need to learn it. Because the market force is going to push you towards robot. And the market force, what will happen is that at the moment, the patients cannot afford it in India. And you have to think of those things. Prices are going to come down as they did for laparoscopy. I remember one of my friends said, he works in a very deprived area in West Bengal. And we were sharing a podium where about 10 years ago, when you're talking about laparoscopic surgery. And I said, oh, how can they afford laparoscopic surgery? He said, Dip, you're wrong. The reason they can afford laparoscopic surgery is because they can go back to work the next day. So I think if you look at the total societal benefits, patients will make these decisions.
Okay. Other questions from the audience, please?
Sorry, say again? Yeah. I left it, but next morning it took out. Yeah. Again, another advantage of this, thank you for that question. You can be so confident because you see everything so clearly, and the 3D view and the depth perception is so good that even if you have bleeding, etc., and actually you don't get bleeding, but the planes are so much easier to traverse.
Next question.
Thank you, Mr. Mukherjee. My question is, you mentioned about the wrap for the giant hiatal hernias. Majority of these patients present with dysphagia, like their symptom is more than reflux, it's dysphagia when it comes to giant hiatal hernias. So, bearing that in mind, I mean, obviously you've reduced it, all that. Don't you think a partial wrap would be okay? I mean, their problem wasn't primarily reflux. What's your comment on that?
I think I probably sort of did not communicate well. These patients' main symptoms are actually not dysphagia. They cannot eat because they get massive chest pain. And what happens is that the stomach, once they start eating, as Peter Karillas showed many years ago, that every time we swallow a bit of air. We are all aerophagic. That's something that was shown about 30 years ago now. And what happens is that bit of the stomach swells up, and they get tremendous chest pain, and they get left shoulder tip pain because it's irritating the diaphragm. And that's something you see in mesenteric-axial volvulus as well as opposed to organoaxial volvulus. So these patients do not have dysphagia that much. If you really, and I think I agree with Dr. Dama, what he said earlier, is that you have to really go through the history. History is everything in these patients, and you have to really know what you are treating. Patient is not bothered about whether they've got reflux or hiatus hernia, etc., etc. They're bothered about their symptoms. Is the symptom regurgitation? Is the symptom vomiting? Is the symptom difficulty in swallowing? And when people say, I cannot eat, that may mean that they cannot eat because the food does not go down. They may not be able to eat because they get pain. They may not be able to eat because they feel full. So these are all slightly different things. And this is why I personally feel, Indian, that benign is much more difficult than cancer. You have to really go through the history. And what you don't want to have is an unhappy patient. And that usually happens not because you have done the operation wrong, but because you have not really taken time to address the patient. And this is a real problem because in benign surgery, for these patients, I would easily spend 30 minutes just listening to them. And they will have a lot to say because they have not been listened to before. So yeah, because we disrupt and the wrap is a matter of personal preference. The reason I like Nissan myself is the durability. Yeah? They all get dysphagia, they all get gas bloat, they all get flatulence. They'll all get that. But I think one of the things that happens, that Nissan wrap always loosens up a bit, enough for all these symptoms to go away. I think the flatulence stays for much longer, as you know. But the great thing is that I have got now 22, 23 years follow-up. I don't see them in the clinic, but I live in the same community, so I bump into them all the time, and they're all happy. You may argue that if I did Watson's all my life, I would have had the same experience. So I think that's... I have used Watson recently in a patient, and that is really interesting. Yeah. It's a patient with scleroderma. And the patient with scleroderma, you do not do fundoplication, right? But what happened is that this patient was just regurgitating and aspirating. So I did a Watson's, and I saw her this Monday just gone, and she came and gave me a hug in the clinic because she was very happy. It's possible that after 6 months she's going to come back and shout at me. I don't know. Sorry, you had a question, I think.
Just a last question. You have said you have a very good volume of paraesophageal hernia. So in your practice, how many cases do you see of short esophagus that you have to tackle surgically?
Is there any American in the audience? Okay. 2 weeks ago, I saw Steve Demister, the man himself who's Tom Demister's son and has been doing this possibly as long as his father has been doing it. But one of the things that he says, in North American practice, they see a lot of short esophagus. If I'm honest with you, I've seen only one short esophagus. However, So we don't do leak-Colles gastroplasty and things like that very much. But can I just add to one thing that we discussed earlier? You have to really dissect. And the whole idea is that you have to reduce the gastroesophageal junction at least 6 to 7 centimeters below the hiatus. You can easily do that by just pulling on the thread, yeah? Don't forget the laparoscopy, the pneumoperitoneum makes it like a cave. So when you leave it, see what it's like. Reduce the pneumoperitoneum, see what it's like. If you've got enough intra-abdominal esophagus, then you're probably okay. If you haven't got it, then you have to dissect more. In my experience, almost always you'll get it down. The other thing is about repair itself, that if you have these very floppy things, the things you can do is to actually make a diaphragmatic release on the right side of the crus. That will give you a pneumothorax, carbothorax. You don't have to often put a drain in either. And then you can repair these things together. I never put a bridging mesh. If you put a bridging mesh, that will fail. So you have to, as Ian said earlier, that you have to stitch it together. And if you cannot stitch it together, do a release, which is very rare. You can do it on the right side by doing a longitudinal cut. On the left side, if you have to release, you have to go circumferentially in the diaphragm to ensure that there is no phrenic injury and things like that. And that will allow you to do that. You may decide to, and this is what Steve Demister does, I have probably done it only once, is that you can actually stitch it, and then where you have the defect in the diaphragm, you can stitch a mesh there, which is a good idea because your hiatus itself has got no tension.
Okay, thank you.
Thank you.
No more questions, and thank you, Dr. Dipankar.